Welcome and thank you for joining us today, everyone. My name is Dr. Shonna Snyder, and I am a member of the Pheo Alliance Board of Directors. I'm going to be your moderator today, and hopefully this is going to be a really fun webinar, and that we're going to talk about things that I think are going to be really pertinent to our patients. And this is a different webinar. We have not really done a webinar about this topic. So I'm looking forward to it today. I am here with Dr. Brent Holmquist, Dr. Whitney Goldner, and Dr. Dhaval Patel. And I'll provide a proper introduction of them here in just a few minutes. But this program is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. We'd like to give a special thanks to Progenics for making this webinar possible through an educational grant. Today is World Net Cancer Day. Pheochromocytomas and paragangliomas are a type of net cancer, and so we celebrate this day to raise awareness with our partner patient advocacy groups. World Net Cancer Day is coordinated by the International Neuroendocrine Cancer Alliance, otherwise known as INCA. And this is an annual event that is held on every November the 10th. It was created to increase awareness of neuroendocrine cancers, to provide a voice to the NET or neuroendocrine tumor community, and to raise awareness about improving diagnosis, treatment, information, care, and research. World Net Cancer Day is about drawing attention to this uncommon form of cancer and starting a global conversation among communities, medical professionals, and governments. One way to do this today is to use the hashtag Let's Talk About Nets. If you're out on social media, anytime you do anything today, if you'll put Let's Talk About Net, hashtag Let's Talk About Nets, that will allow the community to kind of see everyone and raise more awareness. So this hashtag invites NET patients around the world to inspire their friends, families, clinicians, and local communities to become ambassadors for NET cancer and to help make a difference. INCA is the global voice for patients with neuroendocrine cancer and genetic neuroendocrine tumors and their caregivers. Their mission is to raise awareness about all types of NETs, push for scientific advancements with a focus on identified unmet needs, and to provide a platform for global collaboration to address the many challenges NET patients and the medical community face in securing a timely diagnosis and accessing optimal treatment, support, and care. INCA represents 32 member organizations from 26 countries located around the globe. Also, we would like to remind everyone that this Tuesday, November 29th, I think that'll be next Tuesday, is Giving Tuesday. And we are encouraging everyone in the Pheo community to mark the occasion by holding a Facebook fundraiser. So from November 15th through December 15th, Facebook, also known as Meta now, will cover the donation processing fees. So 100% of your donations will go to the Pheo Alliance. In addition, Facebook has pledged to match any reoccurring donations set up during this time. We will be posting more information about this on our Facebook page very soon. So be ready to pay attention to that and kind of watch for that to pop up. All right, so the disclaimer for today's conversation is that the information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and or medical team, because they have in-depth knowledge of your medical history and current situation. So on today's agenda, what we're going to do is I'm going to introduce our guest experts, and then I'm going to share a little bit about my story, and then that will lead us into some questions with our expert panelists. And so we'll have a discussion, and it'll be about 30 minutes, and then we're going to take questions from the audience. So if you have questions along the way, please put them in the chat. We'll be looking at those, we'll be collecting those, and then at the end, we'll be asking some of those questions. All right, so without further ado, let me introduce our guest experts. We have Dr. Brent Holmquist, who received his medical degree from Creighton University School of Medicine in Omaha, Nebraska. He went on to Clarkson Family Medicine Residency Program, graduating in 2011. He spent the next 10 years with CHI in Omaha, practicing outpatient primary care to all ages. He then formed his own solo direct primary care clinic in 2021 called Good Life Medicine DPC, where he works alongside his clinical manager, nurse, phlebotomist wife, Melissa. All right, nice to have you. Dr. Whitney Goldner is an endocrinologist in the Diabetes, Endocrinology, and Metabolism Division at the University of Nebraska Medical Center. She specializes in endocrine tumors, including thyroid cancer and thyroid nodules, parathyroid tumors, adrenal tumors, and other neuroendocrine tumors. She is the medical director of the multidisciplinary thyroid and endocrine tumor program for Nebraska Medicine. She is also involved in clinical research and is the PI of the Buffett, I think I said that right, Cancer Center, Bioinformatics, and Biospecimen Registry. She is active in the Endocrine Society, the American Thyroid Association, the National Cancer Collaborative Network, and the ABIM. Welcome. Dr. Dhaval Patel is a board-certified general surgeon who specializes in endocrine surgery. He has joined the practice of Dr. Harold Chung Loy and Dr. Vincent Moss and is excited to be a part of the Hackensack Meridian Medical Group team. Prior to joining this team, Dr. Patel was an assistant professor of surgery at the Medical College of Wisconsin and the National Institute of Health. He has been published in leading journals such as New England Journal of Medicine and the Annals of Surgery. He is a fellow of the American College of Surgeons and an active committee member of the American Association for Endocrine Surgeons. He is also a member of the Association for Academic Surgery, sorry, I'm having a hard time with that, Academic Surgery, and the Society of Surgical Oncology, the Endocrine Society, and the American Association of Clinical Oncologists. All right, welcome. We have a great panel and we're looking forward to having a great conversation. So a lot of introductions there. Let's kind of dive in and dig into this. So today we are going to focus our webinar on communicating with our doctors, our medical teams. How can we communicate better? That's really the focus. We want to do anything that we can to decrease the time it takes to get diagnosed with pheopara, and then increase the options for treatment and follow-up care. Those things cannot be done without good communication. As a bladder paraganglioma patient, I actually can now kind of look back and estimate that I probably had my tumor for almost 20 years. During those years, I presented with many symptoms that now I know were caused by my tumor. On one occasion in 2001, I simply had one small drink of alcohol, purely, it was purely nothing that anyone would think anything of. And I ended up in the emergency room, fully tachycardic, thinking I was having a heart attack. By the time the ambulance got me in, they said, well, nothing's wrong with you. And so this kind of went on for a while. And as the years sort of went on, I had a lot of different symptoms. A lot of them mimicked kind of thyroid conditions. I had multiple thyroid tests along the way from many, many different doctors who kept kind of asking, maybe this is a thyroid problem. And of course, everything kept coming back normal over, years this was happening. At one point, I started having a headache disorder. And so primary care physician ordered a head CT, normal. I was getting vertigo to the point of throwing up. I was hearing my heartbeat in my right ear, sent to an ENT, multiple tests, everything was normal. And I could go on and on and on. So this lasted for a period of really about 20 years. In 2018, however, my symptoms started to exacerbate. They got very debilitating. I was having a hard time working. I was in and out of the emergency room, most of the time thinking I was having a heart attack. I felt like I was having a heart attack. ER doctors started to, at that point, then think I had a mental health problem and started to suggest medication in that regard. However, I knew there was something wrong. So my background is in health education, kinesiology, wellness. So I knew there was something wrong, but I just didn't know what it was. And along the way, none of these doctors, of course, looking back now, knowing what I know now, none of these doctors picked up on any of the clues that this could be a pheochromocytoma or a paraganglioma. So therefore, I never had any tests that I needed to determine if that's what this was. So at this point in time, I started to kind of use my educational background as a researcher. And I did have a friend kind of midway through this. It was probably, in 2000, I would say maybe 12. I had a friend who was an ER doc, a good friend of mine, and just kind of happenstance, he said, maybe you have a pheochromocytoma. And it was the first time I ever actually heard the word. But it wasn't until 5-6 years later that I actually started to do my own research. And as I researched, that word came up again and I remembered it. And I thought, you know what, maybe he was right all those years ago. And so as I did more and more research and dug into the medical journals, I, at that point then, because of how my symptoms were presenting at that point, said, I think I have a bladder paraganglioma. I started saying this to doctors actually. And I actually started requesting a CAT scan, a CT. It took me 18 months to get that CT. And in those 18 months, I became bedridden. I became unable to work. It was very, very bad. And finally, an ER doctor listened to me, really, really listened to me, did the CAT scan. And sure enough, exactly what I said it was, bladder paraganglioma, lit up like a Christmas tree. And so from there, I began to kind of get the path to get to surgery. So my docs are all at the NIH. Like every other PheoPara patient, I have a story, and there are many, many more parts to that story. That's a quick synopsis of it. But I think it relates to today's discussion because I was communicating. I was asking questions. I was requesting certain tests, and I wasn't getting those things. And none of my doctors were picking up on these clues. So this communication is so important. And so having kind of put my story out there, I want to pose the first question, and I'll send this to Dr. Holmquist. What could a patient like myself do better, do you think, in a situation like this, or, situations that you've been involved in? What can patients do better to kind of express themselves, say what their symptoms are, so that when they're working with their primary care provider, because that's typically who they see first, can help them either reach a diagnosis more quickly or get that referral to a specialist that they really need? If a patient suspects something rare, what can they do?
Right. And your situation is, I don't think, any different from a lot of other patients who are trying to figure out a diagnosis. Most people want a firm diagnosis to put their hat on to explain their symptoms, right? So when test after test comes back, and it comes back negative, or there's nothing wrong, that doesn't validate their symptoms. They want some validation to say there's something actually going on here. So what you did, and your path to getting that diagnosis, obviously it's pretty common. In primary care, I'm a family physician, and so I see a lot of different things, and we're trained for looking at common issues, because we see those commonly. We don't see the rare things nearly as much as obviously tertiary specialists. So it does take some convincing of some of the primary care docs that, hey, explore this option a little bit more. In my experience, the biggest thing that primary care doctors can give their patients is their time. And so in order to really give more time to the symptoms and kind of work through that, I generally want people to be prepared for those visits, meaning act like it's almost act like it's a job interview. Go in and have all your history written out, have all of your medications written out, have all your past history, everything that's been done. In my experience, the people who write those out and actually list those in kind of bullet form, that helps tremendously, because half of our visit, depending on how long your visit is, half of your visit is dealt with. Well, we need to look at your medications. Oh, I don't know what I'm taking, or my doses. I don't know what my dose is. I don't know how any of that stuff. Those people who come in unprepared for their visits, we spend the majority of the visit on those kinds of things and not the actual symptoms. So coming into those visits with just being prepared, and most people who are thinking of a rare diagnosis, their medical literacy is probably pretty good. They know, they've been through many visits already, whether it's with that primary care doc or some other primary care doctor, or a specialist, or ER, or whatever. So for most of those people, they kind of know what the questions are going to be. So again, being prepared for those is really important. So if you can give that information to your doctor initially, and then come in saying, okay, I would like to talk about this, because we've done all the conservative things, we've tried these medications, and they're not helping. So can we talk a little bit about something that I found that might fit the bill, might fit the symptoms. Personally, I think that I hope that I'm humble enough to say, I don't know all this. You guys know way more about this. The patients who have these symptoms, they've done some of the research. You guys know way more than I do about this. My job is to listen to that and take that next step, and maybe a CT scan isn't the correct imaging test, maybe an MRI is, but listening to those concerns and validating.
Dr. Patel, Dr. Goldner, would you like to weigh in?
Sure. So I completely agree with Dr. Holmquist. I think that listening, and a lot of times if the patients have done a lot of research on their own, they've put a lot of thought into this. And so I think at least taking the time to kind of go through that with people is very valuable. Now, I'm in a slightly different position, because by the time they get to me, they already have, they've been through probably lots of workups. And so their referral is fairly pointed. They're looking for an endocrine reason for their symptoms. And so one of my, I guess, rules of thumb is, if it even crosses my mind as a potential etiology, then it's my job to rule it out, because
yes,
I would say more people don't follow the textbook for their symptoms than do. And so even though it's great if people can walk in and you say, oh my gosh, that's exactly what I thought it would look like, I would say the vast majority don't. And so any kind of odd symptom that you can't really explain, and they really have had a very thorough workup prior to that point, if I feel like there could be any sort of contributing factors from catecholamine excess or something like that, then it's fairly easy to screen for if we do it properly. As probably everybody on the call knows, it's not you have to be aware of what meds they've been taking and what food they've been eating and all that kind of stuff. So not to do it willy-nilly, but to screen somebody for at least a secreting pheochromocytoma or paraganglioma is something that I think is worth doing if it even crosses my mind, or like Dr. Holmquist said, if it crosses the patient's mind. Maybe the symptoms don't sound really classic to me, but if it's something that keeps people up at night and they're wondering, do I have this? We can screen for it. And if it's not that, then you can move on to whatever it is that is actually causing them those symptoms, because something's causing them to feel badly, and it's not going to always be that. And so that's kind of my rule of thumb. What's I think harder is when they're non-secreting and it's symptoms of kind of mass
Right.
effect and stuff, because then they may not present with those symptoms of catecholamine excess and it's more non-specific. And usually in the world of endocrine, we start with the biochemical workup before we just jump straight to imaging, because there's so many endocrine organs that have growths in them that are of no consequence. And so it's a little hard to know whether they are something to worry about or not if you just get imaging first. So we always start with the biochemical one, but the non-secretors are not going to necessarily show up. So those are the ones that sometimes are a little bit harder to know what to do. And I guess I would lastly say sometimes there's a lot of tests that are borderline. And so we need to do the testing a couple different times or a couple different ways, both urine and serum, or we do it with different conditions. And so it's not always as straightforward as we want it to be.
Yes, absolutely. Dr. Patel.
Yeah, I agree with Dr. Holmquist and Dr. Goldner. A lot of times, if something crosses my mind, I think it should be ruled out. I'm also kind of at the more the end of the line. Usually they've seen a primary care physician, they've seen an endocrinologist, they have a biochemical diagnosis of like pheochromocytoma or some sort of endocrine disease, and then they're referred to surgery. But I will tell you, for me personally, when I do, and occasionally I'll pick up things too, just in the hospital for they're in the hospital for something else. And for me, at least, I always try to keep, people say, oh, maybe it's in your head or anything. I try to keep that at the very bottom. I always say it has to be something organic first. And like Dr. Goldner said, not everybody's body reads the textbook. And so there's always these non-specific symptoms that come up. And if a patient mentions it to me, I feel obligated to rule it out at least, or at least find some sort of way of saying, well, maybe it's not this. But most of the time I'll just go ahead and check because the patient knows their body way better than I'll ever know. And that's just the fact.
And I'll just let's just have a little bit of a conversation here. What would you say to a person who did feel like maybe their symptoms, aligned in some way with the pheopara, but their doctor is just not listening. They're doing those things. They're coming in. This is my list of symptoms. I'm monitoring these things. I've read about this. I think this is a possibility. And they can't get their doctor to maybe run the test or even listen to them at all because this is such a rare thing. What advice would you give to that patient? And I'll let anybody who wants to jump out there on that one.
Yeah, I can jump in on that one. So, I actually run into this not all that uncommonly where, again, not pheopara, but just in other instances where, someone has seen another primary care doc and they don't feel like they're being heard. They've had a workup for, the whatever issue they're complaining about. Having a fresh set of ears, and this certainly is with the specialists as well. Having that fresh set of ears and eyes to look at the situation and say, okay, how can we do this, a bit differently? If someone comes in, again, to me as a kind of second primary care opinion, and they're saying, I've got these symptoms, I kind of look it up and say, this kind of looks like this. We can, and if the workup is relatively simple to do, again, from our perspective, I have no problem with doing part of that workup, doing our part, and then if it looks like it's something like a Pheo or paraganglioma, sending them on, doing my part, and then sending them on to a specialist. So yeah, again, I think a lot of the primary care docs out there, they feel uncomfortable with these things. So I don't know if they ignore it or they just don't have the time for it. But again, if you come in with that pattern of these symptoms and you've done this workup, I think it's imperative on us to take that next step and not just say conservative treatment. So.
Yeah, I would
And-
agree. I think that if you don't feel like you're being heard, get another opinion. And I certainly have had people who directly, self-referred, specifically because they're concerned about that in particular. They may come in and say, I'm really concerned, I have a pheochromocytoma. Can I be evaluated? And so I know that everybody's insurance plans are different about whether you need a referral or not, but that's always a possibility too.
Good, good. Okay, let's take another question here. So think back to a patient that you have had who did wind up having a pheopera. What made you think of that? What happened with that patient, with the conversation? What was it with that patient that you were like, I think this could be that? Whether the patient said it or not, what was it?
I guess I'll start. As
Okay.
I already mentioned, most of them don't. I would say that probably the ones I thought were Pheos or paras were not. And the ones that I didn't think were probably were more often than not. So that's why we have tests that can help us, right?
Yes.
I would say sometimes it is because I'm doing a workup for secondary causes of hypertension. I think that a lot of times we just say that hypertension is just, as we age, or it's idiopathic or essential hypertension. And that's not, that's not always the case for people. And so that's maybe why it goes unnoticed for a while. So again, I'm in a slightly different position because they're coming because somebody identified that there might be another cause for it, right? But I may be looking at that, or the combination of, sometimes I've seen people who have kind of the hypertension, headache you mentioned for yourself personally. Nausea sometimes can be kind of an unusual symptom for people. But I also have seen people who just have hemodynamic instability. So some of the people that I've seen in the hospital can go from very hypertensive to almost hypotensive to hyper to hypo, and that might be a reason to screen them. Is that what you had to? Yeah. And it's hard to screen somebody in the hospital when they're having a hypertensive crisis, because that's not the best time to get all that workup done, which is why sometimes it can be hard to interpret. So, I think that it's some of those things where like it just didn't all fit with with just a run-of-the-mill diagnosis, which is why we then, looked further. So, and sometimes, like I said, I'm surprised. I did it because I felt like, well, it crossed my mind, and then they're positive. Whereas somebody else who I felt like had classic symptoms, I do it, and I maybe do it more than once, and it's negative. So, yeah.
Anything else that popped up with a patient that you can think of that you had that you were like, oh, that's what I think they might have? Anything else?
So I'll be honest. I've had one patient with a Pheo, but I didn't diagnose it. It was someone who I had inherited, or I think they came to me later on, and it had already been dealt with. So, again, from primary care perspective, there's a lot of things that cause hypertension, tachycardia, bradycardia, single episodes, etc. Nausea. I mean, there's obviously a litany of things that cause those. And again, common things being common, we have to deal with those things first, unless if there's like those red flag symptoms that say, hey, you know what, this we got to really look at Pheo here. And so from again, my perspective, looking at those like a hypertension case, the vast majority of people with hypertension are just metabolically unwell, and they eat like garbage and so forth. Although there are certainly those with genetic causes as well, but the vast majority of them we deal with through lifestyle changes, and don't think of Pheo initially, particularly if they don't have the classic symptoms, and treat those as such. And that's, I think, one of the reasons why it takes so long for just rare diagnosis in general, is that there's so much overlap in those symptoms, because they're all relatively non-specific by themselves. So we're all trained to recognize patterns to reach a diagnosis, or to how we think about working something up. Those little branches of if this then this. That's, I think, one of the reasons why it obviously takes so long for these things to be coming out.
Good. Thanks. So let me throw another one out here for us. So an issue that we often hear is that a Pheo patient would have been maybe sent from doctor to doctor, or maybe they themselves are just going from doctor to doctor, because either they're not finding diagnosis or, for whatever reason. And what they find is, what we hear a lot is that the doctors that they've been to don't communicate with each other. I would say, even in some of my own doctors that I have seen, even after being diagnosed, I have doctors that are supposed to be on my team locally here, and they don't communicate with each other. How do we address this? Like, how can doctors communicate with each other a little bit better so that we can eliminate maybe some of these breakdowns that exist with this lack of communication, so that we can really better help patients? What are some things that might come to your mind that docs can do?
Sure.
Dr. Patel?
Yeah, so I think probably the most important thing that doctors amongst themselves can do is really multidisciplinary conferences. When we had a lot of patients with Pheo coming through the NIH, we would sit down, endocrinology, radiology, the surgeons, and everyone would just discuss these patients. Each patient would be discussed for a good 20 minutes or so, just going through everything, the diagnosis, the imaging, the surgical plan, whether the patient even needed surgery, what other treatment options they had. So I think multidisciplinary type conferences amongst doctors is the most helpful in making sure everyone is communicating. Or even if you're a patient, advocating to whoever is the lead person, saying, can you ask the other doctors to, get together and have a conversation? I think that makes a huge difference. I always work with an endocrinologist on any type of endocrine disease. And so I'm in constant communication with them, calling them back and forth. But the best is to have, all the doctors all in one spot. So that's my 2 cents.
Yeah, I love that answer. That's a great answer. Anyone else have some ideas of, how we can help patients who, kind of have docs maybe strung out everywhere?
Yeah, no, I completely agree. I think it's ideal if you have a multidisciplinary group. We have the same thing where we have a weekly conference. We discuss cases where there's multiple physicians involved, but I think it's also, and so yes, we have each other's cell phones and we text if we're not all in clinic together and make sure we follow up. But I also think it's important to make sure that we're looping in the primary care physician and, sending notes after we see patients. But, one thing that is hard, I think, from both sides, when primary care send them to us and we send them back to them, we get 1 million notes a day. And so it's hard to remember all those things. So one of the things that I think is helpful, or at least I think can facilitate that communication, is even just like talking once initially when the diagnosis is made between the two physicians, and then knowing that, okay, we're going to send notes back and forth just to update you. But if there's something that comes up that really we need to talk about, then we can talk again because we now know each other. I think that, like you said, across the country or different locations can be even harder between groups. And to be quite honest, we're a little bit at the mercy of if we know the address to send it to. Sometimes I may have the address of all my local referring physicians, but I may not know somebody that's in a different state, or how to reach out to them. Not that I'm not willing, just that I'm, I may not know how to. And so sometimes I think what I find really helpful from the patient standpoint is if they make a point of reminding me, or even have the address or phone number or fax or something that they can give to me, because
Yes.
you know, they sometimes will say, oh, now are you making sure you tell my primary care physician? And if I say maybe didn't know who it was or had forgotten, because we're all human, you know, we try to communicate, but we're all human, then I would, you know, in the middle of the visit say, yep, let me make sure I've got the right one. Okay, is this where they're located? And if not, I can take the address and make a point of doing that. And so that's what I try to do. I'm sure it's not perfect, because we're all, you know, the systems are big systems that try and communicate, but I personally, I feel like picking up the phone and communicating, I'm never, ever, upset by that. I love to hear from other physicians and would rather just, you know, talk about it. I may be old fashioned. My kids would probably say I'm out of touch, but using a phone, but I really do think there's still value in that. So.
Yeah, I would you know, completely agree with that. That to me, the specialists that I use them because they are communicating back to me, and I try to reciprocate that to them as well. So when I'm, you know, initially referring someone to a specialist, you know, I really try to, you know, give a good summary. You know, if we're not talking verbally, you know, good written summary of the questions that I'm asking, or what the work that's been done, and then what were kind of the clinical questions that we want to know about. But the specialists that in my mind are the best are the ones that give me a call, at least the first visit, and at least let me know what's the direction that we're going with this. As long as I know the direction and you know that the patient's in good hands, that is then, you know, notes, written notes after that is totally fine. Second thing I'd say is, you know, communicating with the primary care physician about, is the patient going to be primarily seeing the specialist? So we see this a lot in oncology, folks, where, you know, once they have a, you know, some sort of cancer, they're seeing oncology, you know, once every 2 weeks, and I don't see them anymore. And so they, you know, it's kind of implicit that they're going to take over pretty much their primary care after they're diagnosed with something. So if I know that the specialist is going to be seeing them pretty regularly, just letting us know, hey, we'll take care of the majority of you know, the issues that are surrounding all this. You know, you may need to see them for you know, something not related to it, and that's fine. But knowing, okay, this is the direction. So the other issues that we're dealing with, and we know kind of what's being done with the, let's say, Pheo.
All right, very good, very good. Excellent answers. So we are going to the audience. Cindy has a question and she is going to ask it herself, I'm hearing.
Hi, thank
Cindy, I think you broke up a little bit. Can you ask it again?
Yes, sorry about that. Thank you for putting on the program tonight. I found out that I have the SDHA gene through some genetic testing for breast cancer. Was finding they said that they could find something else. So the question is, I've gone through testing. I have an excellent endocrinologist. He hasn't found anything, which is awesome. I've done a lot of research on Pheo and Pheo. How often someone that's symptom-free should they get tested with MRIs or blood tests or urine tests?
I can take
Dr.
that. Yeah. Yeah, no, that is increasingly becoming a reason that we are finding people who have genetic predisposition for parapheo, is because they're getting genetic testing for, say, a different reason, but then they are found to have a, you know, germline mutation, and the SDH mutations are one of the more common ones. And so it's if you've been doing lots of research, you probably are noticing that it's a quickly evolving field. But currently, I would say we're finding a lot more SDHAs than we ever knew were out there. And the current recommendations are not only to do kind of the baseline testing, which it sounds like you've had biochemically, and then I usually do a baseline imaging because again, they may be non-secreting. And then even if it's negative the first time, I still tend to do the biochemical testing with the metanephrines and norepinephrines yearly, at least initially, but reserve the imaging for about every 3 years. That was one of the more recent consensus statements that came out. As long as there's nothing that makes me worried that they have something else, like you said, if they're completely asymptomatic. If they become symptomatic for, with anything, that might change the plan. But if it's purely just on a surveillance basis, I would do yearly blood. And I tend to do blood just because it's easier than urine, but you could do urine also. And then the imaging, if you can do it all as MRI, you can minimize the amount of radiation exposure that you get. Some places will offer a whole body MRI, but not every place does. And so if that's the case, then I do as much with MRI as I can. So I generally do neck and abdomen with MRI, and then maybe like a screening low res CT of their chest, just so I'm minimizing the radiation if I'm purely doing it for screening. Those aren't great if you're looking at a mass, but it can be a place to start is what I do.
Excellent. Let me ask a question sort of in this same line to Dr. Holmquist. So if you had a patient who you suspected had a pheo or para, would you order the metanephrine yourself, or would you refer that out to an endocrinologist? Kind of where are you in kind of primary care?
Yeah.
What is your mindset on that?
I think personally, I would probably order it myself. I don't think they're that hard. So I think it just depends on the test that we're talking about. There's some more complicated blood protocols that certainly for some endocrine tumors and whatnot. Those workups can be a little bit more challenging, and I wouldn't have the ability to do those, and a lot of endocrine offices would do that. But again, it just depends on comfort level. I know some primary care docs would, say if they thought about it, and then they would just, send them on to endocrinology. But I would feel personally, comfortable doing some of the workup at least.
Pros and cons, and I can ask Dr. Goldner to weigh in on this one too. What do you think the pros and cons may be to have that test done at the primary care level versus the endocrinology level?
I think one of it is just you're generally going to have hopefully one less visit. So if you get some of that workup, from your last primary care visits, and you get the workup after that, and you get some of those results, and they point towards Pheo, you can send them on to endocrinology, and then they'll have some of that to review. And so if you don't do that, then endocrine would have the first consult, and then they would do the workup, and then probably have them follow up again. So it's just another visit, just more inconvenient for patients. So that's one of the reasons I generally do at least part of the workup for something for a specialist, but maybe not the entire workup.
Yeah, I would
Anything
agree with that. I think if you're comfortable with it, we appreciate any amount of workup that's been done before they come, because that might minimize the number of extra visits. As we mentioned before, sometimes these tests are prone to some false positives and things. And so it's not unreasonable to start with it. And then if they're a little off, and then we can, decide if they need to be done again. I wouldn't expect the primary care to have to work through that whole process of, what do you have to stop or not, or what conditions are there, but at least it's a place to start. Because the other way to think about it is if they're completely normal, then you can actually try and look at other etiologies or other causes for what's causing their symptoms. And they maybe don't need an endocrine visit if it's a non-endocrine issue,
Yeah. Good. Estella, we have another question from the audience. I think Estella, are you there? Do you have a question for
Yes,
us?
hi. Hello.
Hi.
How are you? Well, my question is, my tumors start shrinking, incredible shrinking after 30 years, and I'm a stage 4. So now I don't know the tumors, if the tumor come back again. Like it's tumors, there was almost 10 centimeters, now they are 5. And the head and neck tumor, the thyroid tumor, and paraganglioma, which is very, very, they say it's more rare than, we think. I have my thyroid tumor, there was 4 centimeters, and now it's 1 centimeter. That this, I think in forward, what are going to do? Like, it's going to be, come back, or this happen, or is, I don't know. Yes, I have the reports. That's why I read the reports, and the doctors can believe, and they have a meeting, because this happened after last year. I did start a diet that I just studied the chemistry, and I take a lot of food. I was stopped last year with sugar and carb, and it's a long list. But something that
Thanks.
everything that I haven't done work, because the tumors shrinking faster.
Thank you,
take
Estella.
30
That's great. That's fantastic news for you. Did you have a specific question that you wanted to ask of our panelists?
Yes, because I see when the tumors get removed, the 80% they can come back by surgery, but mine, that is going away this way. Like, do I have a chance that these tumors growing again? Or
Okay,
I don't
so
know.
let's ask our panelists if they want to weigh in on any of Estella's questions.
Thank you.
Thank you.
So Estella, were your tumors gone entirely at any point in time, or have they always been there?
No, the last month when I have a CT scan or PET scan or one of those, I have head and neck, and I have bilateral on my neck, and I have my left lobe on my thyroid. All the tumors, there was more than 4 centimeters. Now they are 1.2, 1.5, but all they shrink in faster. They shrink very fast. They growing in 30 years, and now they shrink.
Yeah,
Okay.
no, I would agree with Shonna. Congratulations. That's great news. I would
Thank
say in general, I personally haven't seen tumors that just shrink on their own. But I'm glad to hear that you have a multidisciplinary group that's talking about it, because if you've got your doctors looking at those scans and kind of looking at your history, they might be able to give you an explanation for what they think is going on in your case in particular. But it sounds like, it's good news from what you've seen from your scan standpoint. And I'm not sure I have a good explanation for that, because I haven't seen a lot regress on their own, but we have seen them kind of stop growing, and kind of stay stable for a long time. So I'm sorry I can't give you any more insight, but that is good news.
Thank
That is
you.
great news. Great news. So let's do 2 more questions. I think we have time, and we might get a third one in. But we have one question from the audience that says, what processes can or should be put in place to educate or create awareness in the medical community of these rare tumors? Dr. Patel?
Sure. So I think the processes that can be created to help raise awareness is having grand rounds, having conferences, educational seminars for physicians to keep up to date I mean, I remember when I started medical school, everything was about the rule of tens. I mean, that's gone completely out the door in the last 10, 15 years. So continuing medical education is really important. And so, you know, those types of things, those seminars, conferences really help. And just keeping people aware of pheochromocytoma paragangliomas, so that they know that if you have these non-specific symptoms, you think about screening them. So I think all of those things are important. And then just educating the next generation, making sure that they know that, you know, when you hear zebras, you know, think about Pheo's paragangliomas.
Excellent. Anything else to add from our panelists? Anything we can do to educate or create awareness in the medical community?
I completely agree.
100%. Very good. My another question, and it's similar, and the answer may actually be the same. What can an organization like the PheoPara Alliance do to help communicate the needs of our community to the medical community? Is there anything you could specifically think about from a patient advocacy group that might help?
Yeah, that's a really good question. I guess it's kind of the reverse of how we normally think about it, but I think you're touching on something that maybe it changes the paradigm a little bit, right? If there is a need for the community to be educated, not just the providers in the community, but the community itself, I think that organizations like this, you know, providing, you know, informational sessions and things is really helpful, because then it helps patients be more educated too. And so then they can come back to our very original question and come and advocate for themselves and ask about it, because they know it's a potential, you know, cause of what their symptoms are. So I would have to put a little more thought into it, because I haven't thought of it that way before, but I think it's a good idea.
Mm-hmm. Anything to add, Dr. Holmquist?
No, I agree. It is a different way of thinking about it, and you know, obviously, you know, looking at the medical community at large, you know, there's a lot of doctors out there, a lot of you know, nurse practitioners, PAs that, you know, aren't exposed to any of this kind of stuff, and so, you know, offering some sort of through some of the you know, like Medscape or some of those online platforms where a lot of people get, you know, free CME. So I don't know if PheoPara does any, sponsors any of those types of educational you know, blurbs on there or videos or, you know, that kind of thing. That, to me, that would be, you'd be reaching, you know, a lot of people in a relatively short amount of time, and it would be fairly inexpensive, I would say. So
We are looking to expand in that area. I can say that. Good. Okay, let me see our time. We have about 5 minutes. I'll let, if there's anyone else in the audience who wants to ask a question, post it now and I'll take a look. And meanwhile, let me go back to some of my questions since we have a couple of minutes. Let me ask one more. What would you say, and we've talked about this a little bit, I guess, what are some of the biggest challenges that come up with communication, whether it be with your patients and their caregivers or other docs? What would you say are some of the biggest challenges that you faced? Ooh, I threw a tough one at you.
yeah. Well, just in general, time is the biggest,
Oh,
our biggest enemy right now. I mean, you know, most of us see so many patients, and you know, we only have so much time during the day, and you know, if we want to, you know, devote a certain amount of time to actually face to face with the patients, you know, devote you know, enough time to document all that, devote enough time to communicate to another physician about those findings. I mean, that takes a lot of time, and so That's a systemic problem. It's not a, one person problem. And there's, I don't know what the right answer is, but trying to add more time to the day, I don't know, but but
If we could all do that.
if we could only. So yeah, to me, that's honestly the biggest challenge from a communication standpoint. If we had as much time as we wanted throughout the day, and I've talked to every single specialist that the person was seeing, and trying to be quote unquote the quarterback. It just doesn't happen. There's only so much time that we have during the day to get those things accomplished.
Yeah. Any other challenges that come to mind, Dr. Patel, Dr. Goldner?
Sure. I think the challenge, that can come is just with the pressures of practice and documenting things and having everything written down. That can really, you want to spend the most time with your patient and listen to them and hear them out. But I think you also have this huge pressure of trying to get everything done in terms of documentation and recording and the electronic medical record. So I think that's a big challenge. As a surgeon, I think the biggest challenge for me communicating is just making sure, I'm on the same page with the endocrinologist, the blockade is done correctly, or however we both feel comfortable, all of those things, and then just communicating with the anesthesiologist. So a lot of it is, at least when they're sent to me surgically, I have to be ready to communicate with like 4 different people as I'm getting them ready for the operating room, including the OR staff. So that I find challenging, but I mean, as long as everyone is on the same page, things turn out okay.
Absolutely. Good. Dr. Goldner, anything?
I would agree. I think that we all sound like we are more than willing and like to communicate with each other. It's just more the constraints of everything else that makes it a little bit hard. So, and I think that probably a lot of people are that way. And so that's why having these things to facilitate communication at the patient level, at the physician level, all kind of helps that process go a little smoother. Every little step helps, I think.
Absolutely. So patients can use that little email button, right? That's in their patient portal. That I think is great. If patients don't know how to use that, I think that's a great thing that they can learn, and ask someone on the nursing staff in their facility to ask, how do I send messages? I think that's something that, just for patients, that's a way that they can communicate and help to facilitate some of that time lack, that you all have. Excellent.
One more comment that I'd say about that is for patient from a patient perspective. At least once when you visit a specialist, if obviously if this is a big problem, ask the specialist or ask your primary care physician, will you call my primary care doctor? Will you call them? Or to me, will you call the specialist and try to figure this part out? When someone specifically says call them, I'm much more likely to do that because they've requested that of me, and I like to think that I follow through with those types of requests. So that to me would be if you don't think your primary care and your specialists are communicating very well, just ask them. Would you call each other?
Excellent tip, and I think patients needed to hear that. Good job. That is great. So let me say thank you. You all have been phenomenal tonight. This has been a great webinar. And again, it's one that we haven't really tackled all that well. So I'm glad that we decided to tackle this. This has been really good. So thank you so much for your time today, because I know it is limited. Thank you for your dedication to your patients and for helping us do a great Net Cancer Day webinar. So thank you very much. We will have this webinar posted up on YouTube here in a few days. Give us a couple days to get it all edited and squared away, and we'll have it out on YouTube. Don't forget to sign up for our e-newsletter and follow us on social media. Use today's hashtag, Let's Talk About Nets. Remember, today is Net Cancer Day. And last, a couple things here, special thanks to Progenics for making this webinar possible through an educational grant. If you would like to donate to PheoPara Alliance, you can do that at pheopara.org/donate. And again, thank you to everyone who attended, especially to our expert panelists. Thank you and have a great afternoon or evening if you're on the East Coast. Bye-bye.
Thanks for inviting us.
Thank you.